Hello friends, welcome to the quick recap of the topic of placenta and some one-liners, important one-liners that you should remember for during your exam. Placenta is called discoid because of its shape. It is called hemochorial because of the direct communication of the trophoblastic tissue with the maternal blood, and deciduate because some part of maternal tissue decidua is also shed at the time of parturition. Now the source of placenta is two, that is fetal and maternal. Fetal source is chorion frondosum and maternal source is decidua basalis. The interstitial implantation is completed by 11th day. This is important to remember. And the arteriocapillary venous system in the mesenchymal core of each villus is completed by 21st day. That is, the tertiary villus is formed by the end of 21st day of the implantation, or 21st day of fertilization, or you can say around 5 weeks post last menstrual period. The portion of chorion that is not in contact with the decidua basalis portion, that is the abembryonic area, it is obliterated by around the 6th week. And the placenta formation takes place from 6th week to 12th week. Till 16th week, increase in thickness and circumference. There is both increase in thickness as well as circumference. After that, only there is a circumferential increase and thickness is not increased after 16th week of gestation. Now coming to gross anatomy of terms, some important points to remember. The diameter is around 15 to 20 centimeter. Thickness at the center is 2.5 centimeter and it decreases as we move towards periphery. Weight of the placenta is around 500 gram if we consider a 3 kg fetus, and the placental to fetal proportion is 1:6. 4/5 of the placenta is of fetal origin and 1/5 is the maternal origin, and maternal origin placenta, it is only decidua and the maternal blood that is present in the intervillous space. When we look at the maternal surface of the placenta, we can point out 15 to 20 cotyledons. They are convex areas, and the line of separation after parturition in a placenta is through decidua spongiosum. This is important MCQ and one-liner MCQ. Now decidual septa, these are the extension of the decidua in between the maternal in between the cotyledons, and it is this tissue is covered by the trophoblastic cells. It helps in the anchoring of placenta to the maternal uterine wall. Intervillous space, which is lined on all sides by syncytiotrophoblast. This is important that on all sides intervillous space is lined by the syncytiotrophoblastic layer, and this intervillous space is filled by maternal blood. Functional unit of placenta is the fetal cotyledon, not the maternal cotyledon that we have seen, which is present on the maternal surface, but the functional unit of placenta is called the fetal cotyledon, or which is also called placentome. If we this can be asked as a simple one-liner at total villi surface, it's around 4 to 14 square meter, and if we add up all the capillary lengths together in a placenta, fetal capillaries length, then it amounts to be around 50 kilometer long. There is no anastomosis of villi blood vessels in placenta. This is an important question you should remember, because when there are blood vessels, we think that anastomosis may occur, but in the villi blood system there is no anastomosis. Hormone synthesis in placenta, this occurs at the syncytiotrophoblast layer. Terminal villus, from outside inward, it is lined by outer syncytiotrophoblast, then the layer of cytatrophoblast, then there is a basement membrane, then central stroma containing fetal capillaries and phagocytic cells, Hofbauer cells. These phagocytic cells are called Hofbauer cells. As the placenta grows till term, what happens, that cytatrophoblast is negligible and the syncytiotrophoblast, at places it becomes very thin and at some places it remains thick. So it is converted to alpha and beta zones. Alpha zones are very thin and these are the places of gaseous exchange, and beta zones, they are the remains of few syncytiotrophoblast at some places, and they are the place of hormone synthesis. And phagocytic cells, Hofbauer cells, are important. They are present in the stroma containing the fetal capillaries and they have a phagocytic nature. They have got IgG surface receptors, and the maternal and the IgG present in the maternal blood. When it gets attached to these receptors, they are engulfed and then transported towards the fetal side. And the important part is that these Hofbauer cells, they can express class II MHC molecules. Here important part to remember is that the syncytiotrophoblast, which is present in the intervillous space, which is lining the intervillous space, that is, you can say, which are also lining the terminal villus, they do not express MHC class 1 or class 2 molecules. Now, the placental circulation can be divided into two, that is the circulation that is occurring from the maternal side, which is the uteroplacental circulation, and the circulation that is taking place from the fetal side, that is the fetoplacental circulation. They are in close proximity, but there is no mixture of maternal and fetal blood, but they run in very close proximity. Total placental capacity is around 500 milliliter. Out of this, in villi, the capacity is 350 milliliter, and in intervillous space it is 150 milliliter. We know that in villi there is fetal blood, so at one particular time the amount of fetal blood in placenta is around 350 milliliter and the amount of maternal blood in intervillous space is around 150 milliliter at a particular time. Now there are intervillous space pressures. They are different during the relaxed phase and during the contraction phase, but the villi pressure, it remains same during both relaxed phase and contraction phase. So during relaxed phase the intervillous space pressure is lower than that of villi pressure, and during contraction phase the intervillous space pressure is higher than the villi pressure. Now there is we know that the placenta, for the formation of placenta, there is trophoblastic invasion into the decidua. Now there is a primary trophoblastic invasion and there is a secondary trophoblastic invasion. By up to 12 weeks there occurs primary trophoblastic invasion into the decidua, which forms the placenta, and later there occurs secondary trophoblastic invasion into the spiral arteries of the trophoblastic tissue by around 12 to 16 weeks of gestation. It is completed by 16 weeks of gestation. The secondary trophoblastic invasion is important because they make the spiral arteries into funnel shaped and they cause them to lose their elasticity, and wide bore, the spiral arteries become wide bore, and the pressure, that is the blood coming through them comes at a higher pressure, and then as soon as it enters the intervillous space the pressure falls. It comes like a jet. Now as the intervillous space in which the maternal blood is continuously flowing, it is lined by syncytiotrophoblast on all layers. So these syncytial sprouts, these cells, they are released into the maternal circulation, and in around 24 hours they amount to be as much high as around 1 lakh in number, and when they enter the maternal circulation they reach the maternal lungs where the lysis occurs. So these syncytial sprouts that they enter the maternal blood circulation from the intervillous space, they are lysed in the lungs. As we have noted that the intervillous space is occupied by maternal blood, and the pressure there is very low, and so it is a sort of stasis of blood, maternal blood takes place, and already pregnancy is a hypercoagulable state, but still there is no coagulation in the intervillous space, because this is prevented by the action, fibrinolytic enzyme activity of the trophoblast, which is lining the intervillous space on all sides. Now fetal blood flow through placenta is 400 ml per minute, so we can say that it is replaced every minute, and the fetal blood flow and the placental the maternal blood flow in the placenta is around 450 to 500 ml per minute, and the quantity at one particular time is 150 ml. So the intervillous space blood, which is of maternal origin, is replaced 3 to 4 times in a minute, and the fetal side it is replaced once in a minute. Placental membrane is around 0.025 millimeter thick, and as the pregnancy advances it becomes thinner by around 0.002 millimeter. These areas are important for gas exchange, and they are called alpha zones, and the beta zones, they are thicker zones, they are the place of hormone synthesis. Decidual changes, there is a fibrinoid degeneration. This is important. This is called as Nitta-Buch's membrane. In decidual changes, there occurs fibrinoid degeneration at the trophoblastic decidual interface. This fibrinoid degeneration, this occurs after the secondary trophoblastic invasion, and it prevents further invasion of the trophoblastic tissue into the decidua. So it limits the extent of trophoblastic invasion, and if this degeneration does not take place, if the Nitta-Buch's membrane is not formed, then the trophoblastic cells, they continue to invade the decidua during whole of the pregnancy, leading to placenta accreta. Now coming to Rohr's striae, these are nothing but the aging changes that is occurring in the placenta. It is the fibrin deposition at the bottom of the intervillous space. What is important? It is present in the intervillous space, not in the villi, and they surround the lowermost part of the villi, which dips in the intervillous space. So they have not got any significance, any clinical significance up till now, but they are just the markers of aging, and they are present in the intervillous space, these Rohr's striae. Now as the placenta, it has got the role of the transfer of various things from maternal to fetal and fetal to maternal side. It is the only communication that the fetus is having with the maternal system. So there occurs diffusion of various substances, molecules across the placenta, but this diffusion is limited by the size. More the size, less is the diffusion. The molecules that are more than 1000 daltons, they cross the placenta very slowly and very less. Simple diffusion, as we know that the placenta has got respiratory action, it has got the excretory action, it has got the nutritive action, it has got the hormonal synthesis action. So now the molecules, they transfer by various mechanisms. So there is simple diffusion, nothing, no ATP is required. The molecule which gets simply transferred from one side to another without the aid of any other mechanism, without the aid of any ATP synthesis. So it is simple diffusion. Simple diffusion occurs in oxygen, carbon dioxide, sodium, chloride, potassium, urea from fetal to maternal side, uric acid from fetal to maternal side, creatinine from fetal to maternal side, water from maternal to fetal side, and fat soluble vitamins from maternal to fetal side. So these all are transferred across placenta by mechanism of simple diffusion. Now oxygen supply to fetus, this may be asked as one liner question, you must remember, is 8 milliliter per kg per minute and is achieved by cord blood flow rate of 165 to 330 ml per minute, which is we see that it's around 400 ml per minute. Now facilitated diffusion Glucose is transported across the placenta from maternal to fetal side by facilitated diffusion. Now fetal fat, it has got dual origin. Some fat is transferred from maternal to fetal side. Like if we see protein, so all of the protein which is present in the fetus is completely of maternal origin. All the glucose completely of maternal origin. But if we consider fat, fetal fat has got dual origin. Some of it crosses the placenta from maternal to fetal side, and also the fetus synthesizes its own fat also by using the various fatty acids. Now cholesterol, don't confuse that cholesterol does not transfer from one maternal to fetal side. It gets transferred, and it is by direct transfer, and cholesterol, especially the LDL component, from the LDL component is the precursor of formation of hormones in the placenta. Now active transport, this means that the energy is required for and it is against the concentration gradient from maternal to fetal side. These involve amino acids, iron, calcium, phosphorus. All of these things are by active transport. It is against the concentration gradient. And also water soluble vitamins. Fat soluble vitamins, they can get transferred by simple diffusion, but water soluble vitamins, they need active transport system from maternal to fetal side. Important MCQ question is that parathormone and calcitonin, don't cross the placenta. Now another, after nutritive, respiratory, excretory functions, there are also enzymatic action of the placenta, like various enzymes like diamine oxidase is present in the placenta, and it helps in the inactivation of the circulatory pressure amines. Now oxytocinase, it neutralizes the oxytocin, and phospholipase A2, it helps in the formation of arachidonic acid. Now barrier function, the barrier function of placenta is not very good, because almost any drug that we use during pregnancy, it can transfer from maternal to fetal side, and almost any antigen, antibody, viruses, bacteria, protozoa, they all transfer from maternal to fetal side. So barrier function is not very much effective of the placenta. And the larger molecules, they are transferred by pinocytosis. The immunoglobulin IgG from maternal blood is also transferred actively by mechanism of this pinocytosis by Hofbauer cells from maternal to fetal circulation. And this transfer of IgG is more so in the later half of pregnancy. This IgG transferred from maternal to fetal circulation, it gives the immunological protection to fetus after birth. Now as the placenta is of fetal origin, and fetal genetic makeup is different from that of mother, so paternal genes are also present in the fetus. It's a sort of foreign body for the maternal system. Still the fetus is not rejected by the maternal system. So there are some mechanism which helps to understand why this rejection is not taking place. There are some hormones and proteins synthesized from the placenta which has got immunosuppressive action. These are like early pregnancy factor, pregnancy associated plasma protein A, and chorionic gonadotropins. These all have got immunosuppressive action. Now villous trophoblast, that is in direct villous trophoblastic tissue, which is this intervillous space where maternal blood is present, where there is an interaction of maternal tissue with the placental tissue which is from fetal origin. It is lined by syncytiotrophoblast, we have discussed earlier. So this villous trophoblastic syncytiotrophoblast, which is in direct contact with the maternal blood and maternal immune system, they do not express HLA class 1 or class 2 molecules. This is important. And the extravillous trophoblast, that is lining the outer side of the placenta, where the trophoblastic invasion is taking place. It expresses HLA class 1 molecules, and also it has got the trophoblast lymphocyte cross reactive antigen on these invasive trophoblastic tissue, which is causing the trophoblastic invasion into the decidua. They express HLA class 1 molecule, and they have got trophoblastic lymphocyte cross reactive antigen, and the maternal system develops antibody against it and blocks these receptors. Although anti-HLA molecules are present in maternal serum, but they do not have any effect in pregnancy. And maternal immune response, it shifts from cell mediated to humoral immunity. And also the natural killer cells in the decidua and HLA class 1 in extravillous trophoblast, that I have already told you, they interact and regulate the trophoblastic invasion. So these are the factors that avoid the rejection of fetal graft from the maternal system. Now the next part, fetal membranes. I will not be taking detailed lecture on it. I will try, because it is a short topic, and I will cover this topic in this lecture only. So fetal membranes, there are two. We will study outer chorion and the inner amnion. Chorion is the remnant of the chorion. When we see the development of the this placenta, there is chorion frondosum, which later develops into placenta, and the chorion, which is present on the embryonic area of the growing fetus. As soon as the pregnancy advances and the fetus grows, this layer gets opposed, and it becomes outer chorion, or you can say chorion leve. And the inner amnion, the inner amnion is around 0.02 to 0.5 millimeter thick, and within outwards, from inside out, the layers of amnion are single layer of cuboidal cells, then basement membrane, then reticular layer, then fibroblastic layer, and the spongy layer. And both the amnion and chorion, they doesn't possess vessels, blood vessels, or nerves or lymphatics. And chorion is thicker than the amnion. Now functions. It is said that amnion may help in formation of lichar amnii. It prevents, when the membranes are intact, it prevents the ascending infection. It acts as a barrier. And during labor, because of the hydrostatic pressure through the lichar amnii on these membranes, it projects out in a wedge-shaped manner and helps in the dilatation of cervix during labor. Also, it has got the enzymatic activity for steroid hormone metabolism, and they are also the source of the arachidonic acid, which are the precursor of prostaglandin E2 and F2 alpha, which during labor are important for the onset of labor. Now, what's the origin of amniotic fluid? There are theories, speculative theories, that it may be transudate from maternal serum through placenta, it may be transudate from fetal circulation through umbilical cord and placenta, it may be transudate through the fetal skin only by up to 20 weeks of gestation. After that, keratinization takes place in the fetal skin, and the transudate is not secreted. And also it is said that it may be contribution from the fetal urine. Fetal urine output is around 400 to 1200 milliliter, and it swallows 200 to 500 ml of amniotic fluid daily. Now, water in the amniotic fluid is replaced every 3 hours. This is important. So, how much amount of amniotic fluid is present at various gestational age? At around 12 weeks, it is 50 milliliter. At 20 weeks, it is 400 ml. It is maximum at 36 to 38 weeks. Remember, it is not maximum at term, but it is maximum at 36 to 38 weeks, around 1 liter. Thereafter, at term, that is 40 weeks, it is 600 to 800 ml. As the pregnancy advances beyond term, 42 weeks it is 400 ml, and at 43 weeks it is only 200 ml is remain. The pH is alkaline, slightly alkaline, and the specific gravity is very low. And if we test osmolality of more than 250 milliosmol per liter, it is suggestive of fetal lung maturity. Now, various color of amniotic fluid and what are its clinical significance. If it is meconium stained, it is said that of fetal distress but in breech and in transverse lie, the meconium stained amniotic fluid has got no significance. Golden color is suggestive of RH incompatibility because of the presence of bilirubin. Greenish yellow, it is or saffron color, it is indicative of post maturity. Then dark colored concealed abruption, and dark brown, or it is said that to be tobacco juice colored, it is seen in IUD. 98 to 90%, 99% of amniotic fluid is water, and only 1 to 2% of solids are present. Now, functions of amniotic fluid during pregnancy. It has got protective effect on the developing fetus. It helps in providing the space. It acts as a shock absorber. It maintains the temperature of the developing fetus and allows the mobility of fetus. In cases of oligohydramnios, where very less amount of liquor is present, there occurs sometimes even amputation of the limbs of the fetus. So it allows in free mobility of the fetus. Now, functions during labor. It helps in the dilatation of cervix because of the hydrostatic pressure and the wedge effect of the membranes. It also acts as a shock absorber during contractions and flushes the birth canal during labor. Now, coming to amniotic fluid index, it is mentioned in the ultrasound reports, and it is usually calculated post 28 weeks of gestation. Before that, it is not of much value. We take the height of the uterus, that is the fundal height, the symphysis pubis. One line, a vertical line from center of the fundus to the symphysis pubis, arbitrary imaginary line. We divide the uterus into 4 quadrants, and one horizontal line which is passing through the maternal umbilicus. So, in this way we divide the uterus per abdominally into 4 quadrants, and maximum, the largest vertical pocket in each quadrant is measured, and when all the 4 quadrant value are added, it gives the AFI. The important thing, when we are taking the largest vertical pocket, always make sure that the umbilicus is not present in that view. Umbilical cord. Now, coming to umbilical cord. Funis, it is also called funis. The average length is 50 centimeter and it varies from 30 to 100 centimeter in length, and same average diameter is 1.5 centimeter, but it varies from 1 to 2.5 centimeter. There are spiral twists and they are present from left to right. False knots are also present. It is because of the localized accumulation of Wharton's jelly, and they should not be confused with the true knots. False knots are very common and true knots are really very rare. So, false knots are not of any clinical significance, but true knots, if they are present, it may jeopardize the fetus in utero. It develops from the connective stalk, which is the band of mesoblastic tissue. Earlier it is present near the caudal aspect, but because of the cephalocaudal folding of the embryo and enlargement of the amniotic cavity, the insertion, it moves from caudal to ventral aspect, and which is present where it is present, in the fetus, and this position at this insertion at the fetal aspect is the same in all cases, but the insertion of umbilical cord in the placenta, it varies from center of placenta to the from the center to in between the periphery. So, the fetal implantation of the umbilical cord is always same, and the placental implantation position is different, may be different. Now, coming to Wharton's jelly, it is present in the umbilical cord. You should know this, that umbilical cord has got Wharton's jelly. And what is Wharton's jelly? It is the elongated cell in the gelatinous fluid. This is because of the mucoid degeneration of the extra embryonic mesodermal cells. And the importance of this Wharton's jelly, it protects the arteries and veins, and it as a shock absorber. Now, before the 16 weeks of gestation, there are 2 umbilical arteries and 2 umbilical veins. Umbilical arteries are the branches of internal iliac arteries. So, there are 2 umbilical arteries and 2 umbilical veins. But after the 4th month, the right umbilical vein, it disappears and only left one is left. So, at term, the umbilical vein which is present in this umbilical cord is nothing but the left umbilical vein which was in early pregnancy. At term, there are 2 umbilical arteries and 1 umbilical vein. If at term after delivery you find that you have got only 1 umbilical vein and 1 umbilical artery, please check. It means that you should thoroughly examine the infant, and make sure that no congenital abnormality is missed. Now, remnant of umbilical vesicle near umbilical insertion of cord. The remnant of umbilical vesicle is present near the umbilical insertion of cord, and allantois is a blind tubular structure. It is present near the fetal insertion of the cord, and it is continuous with the fetal bladder, may be continuous. Then obliterated extra embryonic coelom. If it is not obliterated, it may lead to congenital umbilical hernia or exomphalos. The umbilical vessels, they do not contain vasa vasorum. Vasa vasorum are the vessels that are supplying the arterial muscles, the muscles present in the arteries itself. So, the vessels that are supplying the vessels are called vasa vasorum. So, umbilical vessels, they do not contain vasa vasorum. This is an important question which can be asked in an MCQ. And umbilical arteries, they do not contain the internal elastic lamina, rather they have got a well developed muscular coat. This helps in the closure of the umbilical arteries after the delivery when the cord is cut. And the cord attachment to placenta, I have told you earlier that it is called eccentric, and it can be present from the center to the periphery anywhere. So, we can say that the cord attachment to placenta can be central if it is present in the center of the placenta. It is called marginal when it is present near the margins, and filamentous is when the umbilical artery and veins, they are inserted into the chorion levae, which is away from the placental margin, and they traverse in the chorion levae and then they enter the placenta. So, these are very delicate. This area is really very delicate, and when this filamentous insertion and these umbilical artery and vein, when they traverse near the internal os, they may get damaged during pervaginal examination, and this is called as vasa previa. If you like the video, please subscribe, like and share the video, and subscribe the channel, and thank you very much for watching. If you have any queries, do ask in comment box. I will be happy to reply.